Today, we're diving into the truly fascinating and honestly rapidly changing world of inflammatory muscle disease. This is a story about a condition that has gone through an incredible scientific revolution, really, in just the last couple of decades. So let's start with a really fundamental question. Just imagine for a second, what happens when the very system that's designed to protect you, your immune system, gets confused and turns against your own body, specifically targeting your muscles? Well, that's the absolute core of inflammatory muscle disease, or IMD. And let's be clear, this isn't the kind of muscle strain you get from a tough workout. This is a systemic autoimmune condition. What's happening on a microscopic level is that immune cells, things like lymphocytes and plasma cells, are actually invading the muscles and causing inflammation. This leads to this gradual onset of weakness and fatigue that develops, over several weeks to even months. Now, for decades, the medical community really felt like they had this mystery solved. The understanding was established, everything was nicely categorized, and it all seemed complete. But, as we're about to see, the story was, well, it was far from over. This right here, this is what everyone thought for a very, very long time was the definitive classification. You had polymyositis and dermatomyositis, which were all about symmetrical weakness in those big proximal muscles, so think your shoulders and your hips. Then you had inclusion body myositis, which was different. You'd see it in older folks, and the weakness was asymmetrical and also hit the distal muscles, like in the hands and feet. This framework, this triad, it seemed to cover everything. But to really, truly understand this disease, let's move away from the textbook for a minute and follow a patient's journey, because this is what brilliantly illustrates how these conditions actually show up in real life. Okay, so our case study is a 45-year-old woman, and that timeline is absolutely crucial. This isn't something that happens overnight. It's a steady, progressive decline over about 2 months. And the number one symptom? Weakness. And it almost always starts subtly. An activity that used to be completely effortless, like just climbing a flight of stairs, suddenly becomes a real challenge. And that points directly to weakness in those large proximal muscles of the pelvic girdle. And the progression continues. See, the same muscles you need to climb stairs are the ones you need to just get up from a chair. So suddenly, everyday life starts to get more and more difficult. Now, here's a really crucial point. This isn't just about the muscles in your arms and legs. The disease can actually progress to involve the muscles of the neck and the esophagus, which leads to something called dysphagia, or difficulty swallowing. And when it affects the respiratory muscles, it can cause dyspnea, shortness of breath. And that is a potentially life-threatening complication. But the muscles aren't the only place this disease leaves its mark. Let's shift our focus to the skin, because sometimes the most revealing clues are literally hiding in plain sight. Okay, in medicine, we have this fantastic word, pathognomonic. It means a sign is so characteristic, if you see it, you've basically confirmed the diagnosis. And for dermatomyositis, Gottron's papules are exactly that. They're these very distinct purplish, flat-topped bumps right over the knuckles. You see this, you have to be thinking dermatomyositis. And the second classic sign is the heliotrope rash. It gets its name from the heliotrope flower, which has the same kind of purplish, violaceous color. It shows up around the eyes, and it's often accompanied by swelling. You put this together with Gottron's papules, and you have a really powerful diagnostic duo. And this just brilliantly illustrates how systemic this disease is. The rashes often pop up in sun-exposed areas, like in the V of the neck or draped across the shoulders like a shawl. Clinicians can even spot changes in the tiny little capillaries of the nail folds. And in the juvenile form of the disease, you can get these calcium deposits forming under the skin, a condition we call calcinosis cutis. So with all these super clear physical signs, you'd think the diagnosis would be pretty straightforward, right? Case closed. But here's the twist that changed everything. What if the most definitive, most important clues were microscopic, hiding inside the patient's own blood? And that leads us to the single biggest shift in understanding IMD, what we now call the antibody revolution. And I mean it. This wasn't just an update. It was a complete rewriting of the rulebook. Scientists started identifying these myositis-specific autoantibodies, basically unique proteins in the blood that act like molecular fingerprints. It turned out each antibody was linked to a very specific pattern of symptoms, of organ involvement, and even prognosis. It offered a level of precision that the old classification could never, ever achieve. And this quote just perfectly captures that paradigm shift. The whole focus moved away from these broad, kind of clumsy clinical labels like polymyositis to a new, much more granular understanding. Today, diagnosing and managing inflammatory muscle disease is fundamentally all about identifying these antibodies. So what does this new antibody-driven map of inflammatory muscle disease actually look like? Let's take a look at how it completely reshaped the entire field.
Just look at this direct comparison. On the left, you've got that old, simple triad. On the right, it has just exploded into this complex spectrum of really distinct syndromes. And notice, polymyositis is now largely replaced by something called anti-synthetase syndrome. Dermatomyositis gets broken down into classic, amyopathic, which means without muscle weakness, juvenile, and cancer-associated forms. And now we have this whole new category for severe necrotizing myopathy. Every single one of these is defined by a specific antibody.
And these fingerprints are incredibly predictive. I mean, this is the real power. If a patient has the anti-Jo1 antibody, a doctor knows to immediately look for severe interstitial lung disease, arthritis, and a specific skin finding called mechanic's hand. The anti-MDA5 antibody, that's a huge red flag for rapidly progressive and often fatal lung disease, even if there's no muscle weakness. And the anti-TIF1 gamma antibody has this incredible dual meaning. In an adult, it screams a high risk of an underlying cancer, but in a child, it points to juvenile dermatomyositis. So the bottom line is this. The diagnosis has totally evolved from just being a simple descriptive label to a predictive molecular profile. Knowing the specific antibody allows clinicians to anticipate complications, to screen for things like cancer, and to tailor treatment with a kind of accuracy that was just unimaginable before. Really, this revolution in myositis is a blueprint for the future, and it leaves us with this really compelling question. As we continue to decode more and more of these molecular fingerprints across the entire spectrum of autoimmune diseases, how is this predictive power going to fundamentally transform the diagnosis, the treatment, and the future for millions of patients all over the world?